Hello everyone, welcome to E-Classes by Dr. Adira. This video is on developmental disturbances affecting jaws. Human development is a complex process that takes place in a highly orchestrated pattern. The embryonic development can be divided into three phases like germinal, embryonic and fetal phase. The germinal phase involves cellular proliferations, cell migration and to an extent cellular differentiations. And it starts from the time of conception and lasts till 2 weeks of intrauterine life. The embryonic phase, which starts from 3rd week and it lasts till 8th week of intrauterine life, is a very important phase as it involves morphogenesis, that is formation of various internal and external structures. And the 3rd phase is largely involving the growth and maturation of embryo, and it starts from 9th week and it continues till birth. The embryonic phase is very important, I told, because any insults that happens at this phase will lead to development of congenital defects. Developmental phase or formational phase, including jaws and oral cavity, is a complex process that involves the development of multiple tissue processes that must merge and fuse in a highly orchestrated pattern, as you can see in these images. So this is a timesheet of development of various craniofacial structures. What you have to understand from this is the development which is very orchestrated because it is controlled by set of genes known as homeobox genes and group of polypeptides known as growth factors. So any insults that happens at the genetic or chromosomal level will lead to anomaly which means something different from normal. So the craniofacial anomalies results because of genetic or chromosomal aberrations as well as due to environmental insults. The environmental insults usually are in the form of teratogens. Teratogens are harmful agents that can cross placenta and cause defects in the developing embryo. And even folic acid deficiency is found to be another important factor that can cause various developmental disturbances. Folic acid deficiency in the pregnant mother or in a woman before pregnancy also will result in various developmental defects. So moving on to the topic developmental disturbances of jaws, I would like to introduce to you few terminologies. That is agnathia, which means absence, complete or partial absence of jaws. Micrognathia meaning smaller jaws. Macrognathia meaning larger jaws. Facial hemihypertrophy, which means enlargement of one side of face. Facial hemiatrophy, which means atrophy of one side of the face. So moving on to the first one, that is agnathia, which means hypoplasia or absence of jaw. It can affect any jaw. It can be a partial or complete agnathia. Here in this image you can see an underdeveloped or hypoplastic mandible. This is an example of partial agnathia. This is usually due to failure of migration of neural crest mesenchyme into maxillary prominence at 4th to 5th week of gestation. We all know neural crest cells are the one contributing to the development of connective tissue of head and neck. So if there is failure of migration of neural crest cells into head and neck region at the very early stage of development, it will result in agnathia. So as I said, it can be complete and partial. Complete agnathia is a rare condition, and if at all happens, it is lethal or causes death of the child, and partial agnathia is a quite common condition. So moving on to the next anomaly, that is micrognathia, which means small jaw. Either maxilla or mandible may be affected. In this image, there is a hypoplastic maxilla, which results in a concave facial profile. Similarly, a hypoplastic mandible will result in severe retrusion of chin, as you can see here, and steep mandibular angle and deficient chin button. These are various conditions seen associated with micrognathia, or in these conditions there will be presence of micrognathia. Includes congenital conditions like Peary-Robin syndrome, intrauterine acquired conditions like congenital syphilis, A syphilitic mother can transfer the infection to the fetus, so that results in congenital syphilis, which even shows micrognathia or hypoplasia of maxilla usually. And chromosomal abnormalities like trisomy 18 Turner syndrome, autosomal dominant inherited conditions like Treacher-Collins syndrome, autoimmune conditions like juvenile chronic arthritis, and acquired conditions like TMJ ankylosis. I will discuss Peary-Robin syndrome and Treacher-Collins syndrome to you. Peary-Robin syndrome is no longer known as a syndrome, it's known as Peary-Robin anomalad. I will tell you what is the difference between an anomalad and syndrome. Now, Peary-Robin anomalad is characterized by cleft palate. As you can see in this image, there is a wide palatal cleft, mandibular micrognathia, that is underdeveloped mandible as you can see here, and glossoptosis. Glossoptosis means backward or posteriorly positioned tongue. Now let's see the etiopathogenesis of Peary-Robin anomalad. So it is initially there is a restriction of mandibular growth in utero, which results in failure of descent of tongue. Tongue is initially at the time of development, initial development, that is by 4th week of intrauterine life, present in a superior position in the primitive oral cavity or stomodium. Mandibular development starts by the time of 6th week of intrauterine life. Once the mandibular development starts, the tongue will descend down to the floor of the mouth, which will allow the secondary palate formation by union of palatine shelves. So when there is failure of descent of tongue into floor of mouth, it will automatically prevent the fusion of palatal shelves. So as you can see in this image, hypoplastic mandible, which is a primary anomaly, will result in failure of descent of tongue, that will in turn result in clefting of palate or preventing the fusion of palatal shelves. So cleft palate is a secondary anomaly. So this is what meant by anomalad. There is malformation with subsequent structural changes. That means a primary anomaly results in other features of this particular syndrome. That's why it's known as an anomalad, not syndrome. When we say syndrome, that means multiple symptoms arising because of a single pathogenesis. Here there is one single primary anomaly that will lead to other subsequent anomalies, which is known as an anomalad. So the clinical features of Peary-Robin anomalad are posterior displacement of tongue, that is glossoptosis, lack of support of tongue musculature, airway obstruction because of the improper position of tongue, and as a result there will be respiratory difficulty, especially when the child is in supine position and there is presence of wide palatal cleft. Next I am moving on to Treacher-Collins syndrome. It is also known as mandibulofacial dysostosis. It is characterized by defects of structures derived from first and second pharyngeal arches, and it's thought to be due to mutation of gene TCOF1, which causes disturbances in origin, migration and interaction of neural crest cells with epithelium of these two arches. Epithelial mesenchymal interaction is important in development. So the features of Treacher-Collins syndrome are an underdeveloped or hypoplastic zygoma, zygomatic bone, downward slanting palpebral fissures can be observed, and there is depressed cheek with a narrow faces or narrow face. There is something known as coloboma, which means a notch in the lower eyelid, and medial to coloboma usually there is absence of eyelashes. And when you see the ear, there will be ear deformity, especially the pinnae of the ear, or sometimes external ear totally will be absent, or ear ossicles will be absent, which may cause in hearing defects. And there is hypoplastic or absence of parotid gland. And there will be hypoplastic mandible with prominent antegonial notching and a protruded chin. So next, moving on to the anomaly known as macrognathia, which means larger jaws, as you can see in this image. There are various conditions which can show macrognathia like pituitary gigantism, Paget's disease, acromegaly, and leontiasis osseosa. The next anomaly known as facial hemihypertrophy. It is a rare developmental anomaly characterized by asymmetric overgrowth of one side of the face, as you can see in this image. Actually, it represents hyperplasia of tissues of one side of the face. So, it's also known as hemifacial hyperplasia. So, there is a facial asymmetry caused by this, and if you see intraorally, there is unilateral enlargement of the tongue. One side of the tongue seems to be enlarged, and there is enlargement of teeth on one side, affected side, and also on the affected side, teeth, the deciduous dentition might show premature shedding, and there will be early eruption of permanent dentition. So that's all about facial hemihypertrophy. The next anomaly, which is known as facial hemiatrophy or atrophy of one side of the face. This is also known as Paddy-Romberg syndrome. So there is slowly progressive atrophy of half of the face. This is the affected side in this image. So there is progressive wasting of subcutaneous fat you can observe in this image. There is atrophy of skin, bone, muscle and underlying cartilages. And oral manifestation, if you see, there will be incomplete root formation, delayed eruption, hemiatrophy of lip and tongue. So that's all about the developmental disturbances affecting jaws. Thank you for listening.